Hi, this is Brian Kim. I'm going to share with you this case of a patient with a dense cataract. It's actually a Catarock and a large pupil and an Hydrus microstent. Now, interestingly enough, as I get the last remaining pieces of the lens, you're going to see a very large anterior capsular tear. I went back and looked at the video. I'm not quite sure what exactly happened, but the point is how can you manage a large anterior capsular tear without propagating the tear? And I'm going to show you the techniques that I use in order to get through this case and try to make it a routine case. And so this is the eye. You can see how large this pupil is, and that's why this corneal marker is really nice, because it allows me to create a well-centered and sized rhexis, not too big, not too small, because even though the pupil size varies, the ring does not vary. It's about 6 millimeters. Using a cotton tip to steady the eye, and this is my paracentesis incision, first on the right side. And then look, I'm going to make my Hydrus incision ahead of time. And so this is the best advice I can give you if you're going to use the Hydrus microstent. Go ahead and make your Hydrus incision early, because you can see already there's limbal vessels in this patient. And you don't want to have blood in the interface when you're trying to put the gonio lens on. And I've done this, and I've had struggles with it. And so now I make my microstent incision early on in the case, so there's no bleeding with the time that you have to place the Hydrus microstent. That's intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and to flatten the anterior capsule. You can see how big this pupil is now. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then when I'm ready, I turn the eye towards me with a cannula, and then I enter. And this is the sharp tip Haldey-Perkar forceps. I go in sideways. You can see the limbal vessels and the bleeding that's in this case. Again, the perfect case to make your Hydrus microstent early. And this is why I do it on every case now. Puncture the center, pull down, grabbing the right side of the tear, going around circumferentially. Again, using that corneal mark that I made to help me achieve a well-centered and sized rhexis. These low-profile forceps are really a fantastic addition to my surgery, and I have exquisite control as I do the rhexis. Finish off the rhexis, burp some viscoelastic out, and this is the Capsulorhexis hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave. That was a little bit of a delineation. Trying to find another spot, and there you go, there's a wave. So it goes all the way through. I'm able to decompress. Try to do another hydrodelineation wave there. I'm actually trying to get a golden ring. It's not quite working for me. I tried to do another ring. Again, it doesn't quite work. Doing a little bit more hydrodissection, decompressing, going to the subincisional area as well, hydrodissecting, freeing up the lens. Going underneath the anterior capsulorhexis edge, doing it on the left side as well, just trying to free up the anterior capsule as much as possible. Irrigating the surface of the eye, lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material. And with these dense lenses, I routinely now perform the terminal chop technique, which involves debulking the central dense core. And by removing the central dense core, you're able to reduce the risk for a posterior plate phenomenon. And what you're going to also do is you're not going to crack from the surface. If you crack from the surface, you'll get that Pac-Man effect, and it makes no sense to try to crack from the top because the attachment point is at the bottom. And so that's why terminal chop is so effective and efficient. I'm going to place the chopper around the lens equator, and then fracturing from the terminal side, which is through and through. And fracturing from that terminal side, you can place the phaco-tip deep between the lens pieces. The chopper is deep. I'm able to fracture the terminal edge where the lens is still attached, and then separate, and that fracture point propagates all the way through and through, and essentially, again, bypasses and overcomes the potential posterior plate phenomenon, because you're not just trying to fracture from the top, you're fracturing down at the posterior adhesion point. Placing the chopper around the right heminucleus, hooking the peripheral lens, pulling it centrally toward the phaco-tip, fracturing the lens against the phaco-tip, which is acting like a chopping block. Placing chopper around that first quadrant, pulling it centrally toward the phaco-tip, essentially performing the same maneuver. Once the pieces are loose, I'm able to, again, surround the lens pieces with the instruments, crushing the lens into smaller pieces, and then emulsifying the lens pieces. Trying to free up that second quadrant. I'm able to loosen it up now. Placing the chopper around that second quadrant, hooking the peripheral lens, again, crushing the lens against the phaco-tip, and again, the phaco-tip's acting like a chopping block for the chopper. Crushing the lens into smaller and smaller pieces, and then using pulses of ultrasonic energy and vacuum to remove the lens pieces. Loosening that fragment up, lifting it out of the bag, crushing it between the instruments, and then emulsifying it. Hooking that piece up, which was a little bit stuck in the bag, hooking it with the chopper, and then crushing it. Again, using the chopper to lift pieces is really helpful. You can see here, this second heminucleus doesn't want to turn. So look what I do. I lift it with the phaco-tip, lift it up out of the bag, and I'm going to fracture that second heminucleus in half, crushing it again and again between the instruments. You can see how dense this lens is, trying to get all the way around it so those chops are through and through. And then that's the scissoring chop maneuver right there. I'm just amputating the posterior adhesion of that fragment, doing the same thing here. And then grasping those free pieces and then emulsifying those lens pieces. So rather than trying to turn this, look, I'm going to get underneath the lens piece, hooking the peripheral lens and popping it up out of the bag. And so again, another way to use that chopper to pop lens pieces up out of the bag. You saw that I was trying to turn that lens piece and it didn't quite work. And if I kept pushing on it, I could cause traction on the zonules. And then you're going to see here, it was good that I didn't do that because I have a large anterior capsule tear. So again, another reason why using the chopper to pop lens pieces up out of the bag is such an advantageous technique. And I believe everyone should know how to do this maneuver in order to reduce the risk of stress on the zonules, but also stress on the capsular bag. So again, using that chopper to hook the subincisional lens piece up, getting around it, rotating the chopper, and then lifting the piece up out of the bag. So I have one last fragment left. And as I'm trying to grab it, you can see all the epinucleus is starting to pop out. So I have to be very mindful, making sure the posterior capsule protected. So again, I'm keeping that chopper deep. I remove all the pieces, and I notice something immediately once all the lens pieces out. You can see here, there is a large anterior capsule tear just underneath the phaco-tip. I still have no idea. I look back at the video, what exactly happened. I guess it's possible as I'm sculpting, maybe I caught the Rexis edge. I did not use trypan blue in this case, and so it's hard to know exactly when it happened. But obviously with mechanical fracturing techniques and utilizing a technique that doesn't depend upon rotating the lens within the capsular bag, I kept rotating forces to a minimum. And remember, when you saw that subincisional piece that was stuck there, if I yanked on it and rotated, I would have totally ripped the anterior capsule and propagated that posteriorly. And so there was a small fragment that was stuck against the cornea. I was able to gently remove that. So I take the chopper out, push BSS in, very carefully pushing BSS as I come out, quickly switching to the INA. And I start subincisionally here, hoping that the tear didn't propagate, and it didn't. And so now I'm removing the rest of the cortex. Again, when you have an anterior capsule tear that's isolated, no different from an Argentinian flag case, it shouldn't propagate further as long as you don't cause it to propagate further. And at this point, I see some fine lens material on the posterior capsule, and I'm debating with myself if I should perseverate and try to polish that stuff off. I don't want to cause any traction on the tear here, and so I'm just very mindful and very carefully trying to remove some of those fine lens materials, but again, trying to balance my judgment with being too aggressive here. And so I decided to switch, put the cohesive in, turn off the infusion, pushing cohesive into the bag, but also on top of the anterior capsule tear there to cause equal distribution of forces above and below the tear. And then I'm going to sweep, but I'm going to sweep away from the tear. I'm trying to go into the subincisional area. There was some fine lens material, so I'm able to grab it and just gently tease it out of the bag. Another nice way to remove some of that cortical material that's stubborn. You can use the sweep in a very controlled manner without having to rely on fluidics, because remember, fluidics, when you have high vacuum like that, it's just unpredictable. You can't react fast enough when the vacuum pressure is so high. And using an instrument like this to peel and separate the lens material, the cortical material, is a very well-controlled way to do that. And so now I'm going to put the single piece acrylic lens into the capsular bag. I think this is the most stable place to put it. You don't want to put a sulcus lens. It'll get late dislocation if you put a sulcus lens, in this case, potentially. And so a single piece acrylic lens into the bag, and then quickly repositioning the lens so that the haptics are away from the tear. To me, this is the best way to position a lens in a long-term stable situation. As I said, putting a 3-piece lens in the sulcus in here is really a bad idea. I've done it in the past, especially early in my career, and some of those patients ended up coming in with a late dislocation. So I'm pushing the anterior capsule leaflets down. I'm filling the eye with cohesive viscoelastic into the cornea, and this is now the Hydrus. So you can imagine, I had this capsule tear, now I have to do the Hydrus. It was a little bit uneasy about it, but I placed the Hydrus in first. This is the way I do it now. Place the Hydrus through the incision first, and then the gonial lens second. And of course, I want to make sure I have an en face view, which means you can see equal amount of cornea and iris. I'm stabbing with the shovel-like end of the Hydrus. I stab through the TM, advance the Hydrus, I flatten out, and as I flatten out, you can see the Hydrus comes out straight in as it should. I pull back the pusher part of the device, and then I push that shovel into the notch, and then push the Hydrus further into the Schlemm's canal. I always like to double check, and so I go back and just make sure that I can see everything clearly. You can see all the windows, and it hasn't done anything funny. It's in position. Go in with the INA going underneath the lens, and I feel comfortable here because the tear is underneath me, so I'm not going to cause any problems with the distal capsule right there. Very important that you don't let the chamber collapse in these cases, because if you do, you just worry about that capsular tear propagating. Especially in these big eyes, when you come out and you let the chamber collapse, the lens tends to pop up anterior to the iris plane. And again, I don't want to do that in this situation. So I move all the viscoelastic in the anterior chamber, and then I'll hydrate my incision. You want to make sure you push BSS as you come out. I'm quickly pushing BSS to prevent chamber collapse, and then quickly try to hydrate my incisions and pushing BSS into the eye at the same time to prevent that collapse. You can see a little bit of heme coming out, which again tells you that the Hydrus is in good position, but you can also see that there was quite a bit of blanching of the conjunctiva away from me over the area of the Hydrus. All of these are good confirmatory signs that the Hydrus is in good position. Again, I'm hydrating all of my incisions, including the Hydrus incision. The lens is in perfect position. The haptics are definitely away from the tear, And these gummy haptics are really advantageous in this kind of situation where you have an anterior capsule tear, no different from like an Argentinian flag case. Like I said, the lens is in perfect, stable situation, and the haptics won't rotate in this case. You can see the fantastic blanching away from me over the Hydrus. And so this is really a dense cataract, a Catarock. I had an anterior capsule tear, but I was able to reduce the risk for propagation of that tear because I don't tend to push on the lens trying to rotate it if I can't make it rotate. And so that's the key. Able to pop it up out of the bag, that subincisional heminucleus. I was able to grab part of it with some vacuum, but then the remaining piece, I use a chopper to get underneath me, hook it, rotate the lens, pop it up out of the bag. And I truly believe that maneuver helped save me, because if I didn't do that, and unbeknownst to me, I had this huge anterior capsule tear. If I rotated it, I'll be literally rotating and propagating and ripping that anterior capsule tear further, and then I would have had lens loss, suddenly vitreous, suddenly the chamber would have been acting strange. And so I'm very confident that these maneuvers that I do every day, every case, are safeguards to allow me to provide better and safer surgery, popping lens pieces up out of the bag, not applying significant torsional stress on the bag and the zonules, are all basic fundamental techniques that I employ on every case. And as a result, I feel like this is really the best way to disassemble the lens and pull pieces up out of the bag. So I hope this was helpful to you, and I thank you for your attention.